Very good morning to you all. Very welcome to have you all here. I always find it really interesting to look at who's coming to join us. And I think the interesting thing for me about this seminar is how many of the people joining us are people who work within the health system. So it's something at the moment, isn't there, about helping people who work within health understand the system that they're in, and helping the rest of the system who don't work in health understand what health is doing. And that feels to be the heart of a lot of our conversations at CDC this morning. Okay, so let me start as people join. So for those, you're all very welcome. For those of you who don't know me, my name is Christine Lenehan and I am the Director of the Council for Disabled Children. And I'm really, really pleased to chair this morning on behalf of my team. So as you can see, one of the things, the heart of life for the Council for Disabled Children is understanding how the system comes together around the needs of children with additional needs and disabilities to deliver the best possible outcomes for that group of children. That, in effect, is everything that we do. And we have a number of programs of work which run across the system, and most of our life is trying to join the dots together. And there are a number of pieces of work that have come together around this system, both the RISE partnership that's in front of you. This is a Department for Education contract, which is about supporting system change and improvement, particularly in areas that are struggling to put together their service for children with SEND in the way that they want to and need to. But alongside this, we also have the pleasure of working with DCOs, DMOs across the country. There are a number of you who have joined us today, and actually that link into a system which is all about coordination is key. And we also work as the strategic partner for the autism and learning disability bit of the NHS in children's work, looking at the development of key working programmes across the system. So our role really is to understand system and system change. Health is a really complex system. For those of you who work in education or in care, believe me, those systems look really simple in comparison to health. You know, health is a world that continues to change, often in a circular way. So many of you who've worked in health know that circle between the regions are in charge. No, it's all centralised. Let's go back to regions. We're going back to regions at the moment. But more than that, we have a fundamental change process in how health is organised. One of the challenges of working with children is that children within a health system are always marginalised, because the health system, in effect, is geared for both acute care and that in its community care for that of the elderly and the long-term disabled. So getting children on agenda is a real challenge. And one of the things we do with our world across the children's sector is we work on something called the Health Policy Influencing Group. If you ever see HPIG and wonder what we're playing at, that's what it is. And really that's about working within health and with systems to look at how do you make sure children are on the agenda. And today's seminar is all about that. It's been built on our understanding, working with colleagues across health, and particularly colleagues in NHSC are always very positive to work with, about building a system that says, okay, where were we? We knew what clinical commissioning groups were, we thought. What is it now that an integrated care board does? How does it work? At what level does it work? Where did the DCOs go? What does all this mean? And how can you map that for children with SEND? So the other thing, of course, that's come out in the last couple of weeks is the SEND and Alternative Provision Improvement Plan. So how do all these bits come together? And how, as we look at system change, do we understand how to move forward? And how are we clear, as this says, who does what? What does an ICS do? What are its duties and how does it work? In all the work that we do, we work in partnership with parents and with young people themselves. So Richard from Leicester City, really good to see a PCF, a Parent Carers Forum, on the call today. because this is key. It's about helping people at the heart of the system, children and families, understand, so what can I expect, what's reasonable to expect, and what does it look like? What I've said to my team is one of the things I'd like to do. As always, you will get all these slides. This session will be recorded and it will be available to you. But what I've said to my team is I'd really like to pull together a resource out of this, so that we have a practical resource, people, as we move forward. And we're really, really lucky today, and I'll introduce them as we go on, to have some really good examples of good practice. And I think that's what we thrive on. Our mantra is, if we can see good practice in the system, then we know what the system can achieve, and so we can encourage other people to achieve it. So that is what we do. Okay. I think 70 participants is about what we were expecting today. So let us move on and actually get into the detail of the programme. Andrew, who leads much of our health work in this area, has got a really good presentation for you on statutory duties, roles and how we work. So let's hand over to Andrew. Just in terms of practicalities before I do, sorry, Andrew, we welcome questions on this presentation. If you've got them, can you put them in the chat and we'll pick them up at the end of the presentation? That'd be really, really helpful. So thank you very much. Andrew.
Great. Thank you, Christine. And for those that don't know me, I'm Andrew Fellowes, Assistant Director in the health team here. And so I'm going to talk through a kind of combination of ICS stuff for the SEND audience and SEND stuff for the ICS audience that we've been doing. People are going to know kind of plenty of this, and some people might know the vast majority, if not all of it. But it is a really changing context, and it's a context that's continually changing, as Christine said, at the national level, that's playing out differently across individual systems. So yeah, I'll put a big health warning on this in terms of it not being a kind of single version of what's happening, or kind of single take. But it's kind of my take and our take on kind of how the new national framework is playing out and kind of been interpreted by local systems and intelligence drawn from different places. So next slide, maybe. I don't know if yes, I'll talk through the kind of ICS guidance and accountabilities, a bit of the kind of timeline that continues to shift, and then some of the intelligence that we've been hearing from system partners and what that looks like in terms of key issues nationally, and it may echo with or kind of diverge from what you've been seeing and hearing, or potentially not seeing and hearing in your own systems. So next slide, please. So everyone will know the kind of the structures on the left. The little color coding just shows different levels of local authority in involvement. But the one thing I wanted to point out on this slide is the Health and Social Care Act wanted to make changes to how the health system worked, integration within the health service and between the health system and other partners. But the original white paper and the initial legislation was extremely adult focused and risk marginalising children and young people. And our point, kind of our view on it was, the Health and Social Care Act is not just asking the system to continue doing what it was doing. And it's, particularly with children and young people's health, it's not we were not in a situation where we felt it was fine for increased focus on integration for adults and the children's system could continue. And so that's why we thought that just transferring the statutory duties as they existed to the ICSs was insufficient. So as part of the health policy influencing group that Christine mentioned, and some very kind of engaged and active members of the House of Lords, we were able to put pressure and secure amendments as the bill was going through, and it introduced some key duties related to children and young people, and specifically children and young people with special educational needs and disabled children, saying that ICSs in different ways needed to do some specific things and have kind of specific representation. And I'll kind of talk through where that got to. So next slide, please. So the first thing is that, and again, people will be looking at this in their own systems. The kind of split that was introduced in ICSs, this happened between the Integrated Care Board and the Integrated Care Partnership. This happened relatively late in the development, at least as far as I could see, relatively late in the development of the policy. There's a lot of talk around ICSs, and then one day there was I remember seeing the presentation by someone from the HSC, and there was this dual fried egg, as I called it. And so there's now different guidance for these different elements. I'll just kind of very quickly run through what each of them does and what it means for SEND. So integrated care boards, which are the kind of representatives of the main kind of elements of the NHS in a local area. They're responsible for basically organising and delivering NHS services to meet the population's need and have budget responsibilities. So they must have an executive lead with accountability for SEND, and those posts, a lot of those are in post or being recruited at the moment. They have to produce a 5-year joint forward plan. Now, this is a slightly strange rolling forward plan. So it sets out what the strategy for the next 5 years is, and then every year, the kind of year that's just gone gets knocked off and a new one gets added to the end. So it's always looking 5 years in the future. That plan needs to set out how the ICB will deliver, one, the ICP strategy, and also deliver its core functions. It must set out how it will address inequalities. There's nothing in the guidance specifically that says it must set out how it will meet the needs of children and young people with special educational need. But in the inequality section, if you follow that through the guidance, it's clear that that includes children and young people with special educational needs and disabled children. It must also set out how it will deliver expectations in the NHS long-term plan, at least while the NHS long-term plan is still in effect. And the kind of most explicit reference there is the range of commitments around learning disability and autism and reducing inpatient care, but it's broader than that, things like the DSR, CETRs, key working programme that Christine spoke about. So the ICB forward plan must set that out, and it must set out how they've met their statutory duties. So that does include safeguarding, and it also includes the SEND duties. There's a high degree of autonomy within this structure. So the plan says there's guidance that says your plan must say how what you're going to do. There's relatively little guidance about within those areas what ICBs can choose to prioritise or choose to do. ICPs are a joint committee of the ICB and the local authorities and other partners in the area. So it looks at the wider kind of social determinants and health inequalities of the population that then informs what the ICB is meant to do. It must develop an integrated care strategy, which is an ICS level version of the health and wellbeing strategy from the health and wellbeing boards, and it's meant to draw on the JSNAs that have been produced by the health and wellbeing boards. Now, obviously, we all know that the quality of JSNAs is massively variable. So you may have some areas, even within an ICS, one ICS where there are some excellent JSNAs that do really set out the kind of needs in detail of disabled children and young people, and you may have some that absolutely don't. But the strategy is written, or the legislation is written, as if there'll always be an excellent JSNA that the ICP can draw on. It must consult children's system leaders, children and young people and families when developing this strategy, and it must promote integration between the NHS and the local authority. But again, exactly what that looks like, it hasn't really been set out. The guidance is pretty light touch when it comes to ICPs, but the guidance does say one thing, and we've heard this reflected by systems in terms of this being something that directors and assistant directors and SROs in ICBs seem to have taken on board, which is, how do you know what you're meant to do at an ICS kind of system level versus place level versus neighbourhood level? And the 3 tests for that principle of subsidiarity. So it's basically saying everything should be done at as local a level as possible unless these criteria apply. So the first is to achieve a critical mass beyond the local population to achieve the best outcome. So is there something, are there a set of issues where commissioning or organising services, it makes more sense, or you'd be able to achieve more by doing it at a system level rather than at a place level? To share best practice and reduce variation, and I'll talk about that a little bit later on, and to achieve better outcomes for people by tackling kind of wicked issues, so complex and intractable problems. So they're all kind of variations of the same thing, but ICSs are looking, or ICPs and ICSs as a whole are using this as a kind of guide in some areas to work out what's going to sit where. Next slide, please. So the one kind of additional point to this that makes it maybe less certain is the Hewitt review. When I say surprise announcement, it was a surprise announcement. I was in a meeting of what's called the NHS England Stakeholder Council the day it was announced, and we'd literally had a presentation saying, and the health and social care and the system is all fixed, and this is what we're going to be working with. And then the announcement was made that it was being reviewed. It's obviously not usual to review government policy before it's implemented. So it shows that there was definitely some issues, concerns within parts of central government about, even at that stage, the direction of travel of ICSs or some of the frameworks. And potentially, Jeremy Hunt as Secretary of State for Health and Social Care, but also the chair of the Health and Social Select Committee, has a long-standing interest in health policy, and it was him who made the announcement. May have been kind of some reflections on his views as well. But anyway, so they asked Patricia Hewitt to lead the review. That has been going on. It was asked to look at 3 particular issues: empowering local leaders and improving outcomes for population. So really giving local leadership greater control. Looking at reducing the scope of national targets. So again, in essence, freeing up ICS leadership to have more discretion about setting priorities, making their own decisions, while maintaining some core degree of kind of central guidance. And then the role of CQC being enhanced in the oversight system. So that emphasis on autonomy and accountability really reflected messaging that was in the NHS operating framework that was published in October, that was in the kind of technical language of an operating framework, was pretty clear, basically saying NHS England needs to refocus its relationship with ICSs and focus on helping local decision making, empowering local leaders, and basically playing a less instructive role. So having less ability to just directly instruct the local system or set kind of clear goals for the local system. So that exact relationship is still being determined. The Hewitt review was meant to be published initially last week, but it's been delayed until the end of March. The Health Policy Influencing Group met with one of the strands of the review. RCPCH has been very involved as well. So we inputted, and all our members kind of inputted the importance of children and young people and not diluting the duties that are in the Act on children and young people. Issues that we know have been discussed or have come up have been the issue of organisational place footprints and the nature of partnerships with other partners, but particularly local authorities. They've all been kind of discussed by the Hewitt review, but we're really not sure what the result of that is going to say and how much it will influence some of the core frameworks and strategies around the ICS. So next slide. So really quickly, I'll run through some of this because this will be more familiar, but yeah, the duties on children and young people all transferred, including those on special educational needs and disabilities. So delivering the Children and Families Act 2014, the Code of Practice, and then the requirement to have an executive lead on the board to make sure that it has sufficient kind of seniority and priority in delivering those functions. but obviously looked after children, children in the youth justice system, mental health requirements and safeguarding also all transferred across. Next slide, please. And yeah, next slide, I think. So we've been thinking about what that might mean in practice. Many of you may have seen the presentation or seen this kind of graphic, which was our initial attempt to start trying to, and we can, we'll circulate this after for those who haven't seen it, but our first attempt to try to work out how the governance structure might work and what it might mean. And I think one of the things that we started doing at that point, and we're continuing to do and talk about in systems, is like, what does it mean in practice for delivery? There's an awful lot of focus on structures, on governance structures, on decision making structures, on the way that the structures from like the ICB board down through the various subgroups and then to place levels, kind of who's going to sit where and what's that, what are they going to be responsible for? That's all really important. I think what's then becomes even more important is what type of decisions will they be making about what services. And I think when we've had discussions with parent carers or lots of professionals as well, that's what really matters. It can't just be a piece of kind of abstract structural governance work. It's about who's going to make decisions about investment, about staffing, about addressing inequalities, in kind of material questions about kind of service redesign and prioritization across the footprint. Next slide, Millie. So here's again our kind of working model of what may fit where. Other areas, ICSs are going to be making those decisions and may not be that far along, but we're trying to get a sense in our kind of monitoring work and talking to systems about, as kind of actual priority programs emerge, what is that going to look like. Next slide, please. Yeah, so the SEND duties that have been placed on ICBs, this will be familiar to almost everyone, but I'll just quickly run through them. But yeah, the duties to bring children to the attention of the local authority, to cooperate with the local authority, generally and in specific circumstances, and generally basically means commissioning, and specific circumstances means EAC plans. And what's really important there is it's still a system, and it's where the local authority is the anchor of the legal duties around kind of assessing and delivering services for children and young people with SEND. So the role of the wider role of the partnership with the local authorities, how it fits in at a place level, is still going to be absolutely vital. And that's an area, as Christina said, where not just for SEND but in general, there's a lot of kind of uncertainty that we're picking up from across the system. Next slide, please. So the commissioning arrangements, and I think there's a real issue here in terms of the subsidiarity point. If the current arrangements are again local authority based, in the local authorities and partner ICBs must put in place joint commissioning arrangements, is that done just on a separate kind of place by place basis, or are there certain elements that the ICB will be able to commission kind of holistically across its footprint, but also in partnership with each individual local authority? There's going to be some tension there, and it's definitely one of the things that we expect to be picked up in the inspections as well. For some areas, it's not necessarily so different from CCGs that straddle multiple local authorities, but it's certainly a much more significant scale. And these issues around accountability and governance arrangements will need to be worked through. Next slide, please, Mary. Local offer, clear issue in terms of how one single ICB is able to reflect a local offer across its partnership footprints, and what's consistent and where there's got variation. And just some of this is just the practical questions and realities that you'll all be grappling with about who'll be doing the actual work in making sure that there is a kind of clear input and process for that changes to the ICB to be reflected in the local offer. Next slide. Yeah, EAC plans, there'll be huge variation, and this will be a really significant issue in terms of how ICBs try and address some of their kind of footprint-wide duties and inequalities duties. We know, everyone knows that in large areas of the system, the EAC planning process is creaking, and it's a system that is getting further away from being able to meet the current statutory requirements, not closer. So next slide, please, Mary. And so how the system's going to kind of deliver those issues are really, really significant. And I think there's a few points that we've been picking out from our work with local areas, and it goes back to that point about kind of what are ICB's kind of decision-making remit at different points going to look like. So we know the new structures are taking shape at the whole system level. And what that means for joint send activities at local authority footprints are kind of being worked through. So I think the tension will be where the overall kind of partnership relationship between the ICS and the local authority are not necessarily yet facilitating strong partnership arrangements, particularly given that the send duties are particularly clear and specific around the partnership working with local authorities. So what does that look like? Need to build and maintain children and young people and send priority at board level. So areas are developing kind of governance arrangements and are defining, what could or should be done at system and place level for send. And there's growing recognition, particularly over probably the last 3 months, 4 months or so, that the exec, having an exec lead with responsibility for send at board level, when that's in a lot of areas going to be somebody who's got responsibility for all of children, and that responsibility is one of the many things that they'll have, won't be sufficient, and there'll need to be kind of robust strategic arrangements kind of sitting under the board. And I personally find it very confusing that the Integrated Care Board is called a board, because it contains an actual board and an organisation, and it can lead to some slight lack of clarity about what is being done literally by the board of execs and what is then delivered as the organisation of the ICB. And I think language will change to reflect that. But the need for a clear structure of kind of a head of send, SROs at place, designated clinical officers, provider leads, like the whole kind of remit of the system that's required to deliver the services for children and young people with special educational needs, rather than just a kind of the gap between having a named exec and then certain people at kind of place level. And I think we're seeing areas trying to construct more of a kind of clear bridge to meet beyond. So it's not just an exec lead who maybe receives the odd report. And those appointments are happening now and will have been made in many places. The point I've already made, it's not just about arrangements. What will the actual decision-making scope be of the governance structures once they're up and running? What are they going to be doing, to put it bluntly? So that can range from kind of oversight and leadership, planning and delivering of specialised services, sharing good practice, setting minimum standards, making investment decisions, developing workforce strategies. But one aspect that I think will be really significant is this question of redistribution across the ICS footprint. So ICSs have been given a kind of requirement to look at reducing inequalities and tackling variation, but that potentially will require the decisions around resource allocation that in essence benefit some and not others. And I think ICSs are not yet clear kind of to what extent that's something that's going to be happening. But if you have an ICS where you've got massive variation in, let's say, length of time it's taking EAC plan assessments to be completed, one of the ways that you can address that is shifting resources. Now, it's not clear that's going to happen, or if people would be happy about that, but I think that's the level of question that will be really important, because I've heard from a lot of ICS children's leads or assistant directors, and they're all saying SEND's one of our priorities, and that's great. Obviously, SEND is an absolutely massive area, and when you start trying to understand, okay, well, what's that going to look like in practice? What are you picking out as your priority work streams to improve your SEND services? They're not there yet. So they're very, it's great that SEND is being written in as a clear priority, but an awful lot of work needs to be done to turn that into kind of practical and deliverable work streams. And then we've got the question
you're
of the
overrunning, Andrew.
All right, I'm pretty much at the end. So,
okay.
But yeah, the relationship of NHS England is up for grabs. So let's skip if you go to the next slide. So data, the only thing I'll highlight here is ICB data is going to have to look at how it's going to relate to the SEND improvement plan, commitment to data dashboards at different levels. The joint inspection framework is the next slide, Millie. So we know that there's been some issues about how ICSs just at a practical level participate in the inspection frameworks, but we think it'll be really interesting to see how the inspection process itself develops your understanding of the ICS as a partner. I just wanted to highlight the provision, the inclusion around dynamic support registers in the inspection framework. I think it's the first time there's been a kind of significant aspect that isn't part of the Children and Families Act, and we do a lot of work on the DSRs and key working. We think that's really positive. The next slide, please. 5 recent cases that, very much what I was talking about earlier. These are the issues that ICSs will be responsible for addressing, unpicking, resolving, and these issues are only kind of rising further up the system in the current context, but the kind of operational and very difficult and very challenging issues between partners that have a massive impact on children, young people, families, and professionals. And I'm sure a lot of you will have seen some of those judgments. And then the last slide, please, Mary. Yeah, so the kind of last slide around where we're expecting further guidance. The executive lead guidance setting out what people are meant to, what the different levels of responsibility should look like. We're expecting that to be published relatively soon, probably impacted by the Hewitt review, but that will provide some degree of further guidance alongside the kind of role descriptors that NHS England are developing for the different leadership roles at the different levels in the system.
It's not.
Quality and short, a SEND quality improvement framework that's in development, looking through the eyes of parents, carers, children and young people, to start defining what the offer to local systems to support change is to make those improvements. Clinical intervention in education settings. So we know that this issue of medical support, school nursing support within education settings is becoming a really significant issue, particularly in light of various kind of unpicking of the legal framework that underpins that, and training for level 4 practitioners as part of the SEND training assurance framework. So that there are some materials, guidance and resources that will be available relatively soon from NHS England to provide some support on this. So yeah, sorry if I feel like I both rattled through that and overrun, which is not the ideal combination, but yeah.
Both of which is true, Andrew. And my apologies, my computer is deciding that the battery is not working, which is very helpful. So if I suddenly disappear, you'll know why. But we will make sure you have all these slides. And Andrew's talked about, so you've got to look that and these resources as they come through. Question from Sally, Andrew, can we share copies of the joint, the local government ombudsman findings, etc.? Have we got the
Yeah,
links?
yes, we'll pull that together. Yeah.
So we'll put a pack together on this, and we will try and keep you up to date. As Andrew said, this is a world that is continuing to change, and obviously, as soon as the Hewitt review launches, we will put that out through the networks and specifically on the DCO website, on the DCO forum. So yeah, does that make sense, Andrew?
Sorry. The last thing that I should have mentioned, we being the Health Policy Influencing Group are undertaking an exercise to review ICS plans when they're being published. Only 5 fully have been published so far, lots of draft ones, and we will do a bit of an analysis to say, okay, what are these plans actually saying? I think the big surprise is the big non-surprise, rather, lots of warm words, lots of positivity. There are very few at the moment that are setting out much in the way of specific outcomes, targets, or real clarity. But we'll pull all that together when we've done all of them.
That's why we were so pleased to see Nottinghamshire's, and we will come to that later on with Michelle. One of the key drivers of understanding what is happening and how it translates, as Andrew said, from the system structure into the system delivery is the role of the inspectorate. And we are really, really pleased to have Lee Pickerel with us. Good morning, Lee. It's always good to see you. As we start to understand this new inspection, what's going on, and what the inspectorate will be looking for as it starts its new world, etc. So I'm going to hand over to Lee. If I suddenly vanish, folks, I apologise. I will try and get my computer fixed. But there you go. Lee, good morning.
Good morning. Good morning, and thanks for inviting me. Some of what I'm going to say we've heard already from Andrew, but what I want to say is never has an inspection framework been launched in the midst of such choppy seas, and changing seas. So what we're talking about today and the inspection framework and what we're looking for, it's going to be a really dynamic process and is subject to change. Don't worry, when you look at the first slide, I'm not going to go through the handbook with you. I'm just going to talk to you about actually it's split into the evaluation schedule, which is in part 1, and actually that describes what we're going to look at. And I am going to talk about parts, sections 31 and 32 later today. It talks about the second part of it looks at how local area partnerships provisioned for children, young people with SEND are going to be inspected. So that's the mechanics of it. So the main inspection, the full main inspection is going to be a week-long inspection. It's going to be with 2 CQC inspectors. You're going to have an adult social care inspector for the first time, which is very exciting. And we're going to have 2 education inspectors. We'll be on site for a week, and at the end of that week we'll be coming to one of 3 judgments. And I want to say here and now, we know we're inspecting, and I'm going to use the words, a broken system. And what we need to be really careful that the 3 findings are not related to the judgments, the graded judgments that both Ofsted and CQC use. So we cannot map them across to the outstanding, good, requires improvement, and inadequate. So we're not even going to try, because what we're very conscious about is if we look for that outstanding, actually nowhere across England is going to meet that benchmark, and actually is that helpful? Now, for those areas where we go into and we make the decision that actually they need extra help, and we've issued what we're going to call a priority action plan. So the priority action plan, if you like, if you're going to draw a parallel, it's against the written statement of action, but awarded against different criteria. For those areas where we think that a priority action plan is needed, we're going to be asking for a plan, and we will be going back to do monitoring inspections. Monitoring inspections may also take place where we become increasingly concerned about a local area. And then the fourth part of the schedule of inspections is the engagement meetings. And I see Matthew's on the call. Matthew, I met Matthew a couple of weeks ago now, where we were trialling what those engagement meetings might look like. So they're going to take place 12 to 18 months, and it's interesting because I think that in itself will be an evolving process, especially as the ICB and ICSs often cover a much larger geographical footprint than a local authority, and it's actually how those engagement meetings become have a local focus and actually are then used by both CQC and the wider ICB ICS partnership to inform those leadership discussions. And then the fourth element of the new framework are thematic inspections, and that's where we're going to identify a topic, a hot topic, and we're going to do almost a deep dive into that to look at what learning there is for the system. So they're very learning, with a learning focus. The first one is around alternative provision, and I think we're halfway through that now. I would say we've done about 5 of the full main inspections at the moment, and I know everybody sat there waiting eagerly for those to be published. They are going through almost an enhanced quality assurance benchmarking exercise, because we're very aware that the benchmarks we set for the judgments for those first few are what we will be measuring future inspections against. So it's really important that we try and get this right. Next slide, please. And, you know, if we look at actually what the purpose of these inspections are, it's actually looking through the lens of children, young people and their families. It's providing that independent external evaluation of the effectiveness of that local areas partnerships arrangements for children and young people. And actually, it's where appropriate recommending what the local area partnership should do to improve the arrangements. And I'm saying that in the midst of everything that Andrew's talked about around that need where you might have to address unwarranted variation and move resources around. It's going to be some really, really interesting conversations that are going to have to take place. But what I'm here to do today is to talk about the type of evidence that we're looking for during inspection, with a focus on the role of the ICB at the moment, with the caveat that what we've just talked about is it may change as the inspections move forward. I think somebody mentioned, I think it was Andrew again, talking about the role of the DSR and the CETRs, and about how actually this is the first time that they're being given that real inspection focus. And we think that it's really important to support our colleagues in the implementation of those, because ultimately they are bringing a lens into how local areas work to support those children and young people who need often that bespoke package of care. Next slide, please. So if we're going to look at section 1 of the framework, and I'm just going to run through what it says, and then I'm going to talk to you about the type of examples that we will be using as evidence. And then actually, if people want to put in the chat things that they think would be good evidence as well, I will steal it and we can use it as part of our approach. So if we look first about how local arrangements are impacting on the experiences and outcomes, and this has all got that children and young people's focus. So it's about how their needs are identified accurately and assessed in a timely and effective way. And you know, that's through things like delivery of the Healthy Child programme. It's about how therapies are contributing to the EHCP processes and also the SEN processes. It's about how school nurses are working, both in terms of mainstream education, but also in special schools. And it's about CAMS, and you know, lots of places are now moving to the I Thrive model with that focus more on there's no such thing as a wrong front door, and then the thorny issue of the ND pathway. It's about how children, young people and their families are participating in decision making, and actually that's at an ICB level as well as about you having oversight in how your commissioned services are involving those families. It's about children and young people receiving the right help at the right time. And I think, you know, a good example was that CAMS model about there being no such thing as the wrong front door. Children and young people, they're well prepared for the next steps and achieve strong outcomes. So traditionally, we're thinking about children in health moving from paediatric services into adult services, and about we're very aware that sometimes thresholds between paediatrics, and by that I include CAMS as well, into adult mental health services, there's very often different criteria. So it's about how commissioners are exploring that gap and making sure that actually our young people, as they move into adulthood, can still access some support that they may need for their outstanding needs. And it's about how children and young people are valued, visible and included in their communities. So I think I've talked about one of the other things that we're also looking at this is about the changes to the designated clinical officers, and about the changes to that role actually, and looking at the impact of what's happening, because I take on board fully what Matthew was saying, is actually there's still a gap in guidance about what that needs to look like and actually what's going to be included in their remit. So I think that that's some guidance that we still need. Does any okay, so Sue is saying waiting lists are so problematic. How are we going to take into account the assessed in a timely way? I absolutely get what you're saying, Sue. So I've been having some very robust discussions because there is a tension with children and young people waiting, and actually about the need for inspectors to be pragmatic. Because if we were to go forward and say that if we were looking at, for example, speech and language therapy, and we were looking at the neurodevelopment pathway, if we were to use just the waiting times as a marker for the first of those three judgments, nobody would get it. And actually that's not helpful. So what we're looking at is how local areas are working together to mitigate risk. So it's about actually what support that local area is putting in place to support children, young people and their families whilst they're waiting. So that's something that we're really clear about when we're now looking at the neurodevelopment path, the diagnostic pathway. We're also looking at actually the local areas are aware of their weights, that they've got clear plans on how to reduce it, and they've got trajectories to monitor it. So I hope that's helpful. In terms of the neurodevelopment pathway. In terms of speech and language, again, another huge national problem. So here we're looking at actually how are the local area working together to make sure that actually speech and language therapy is not just for the core team of speech and language therapists. It's about how the local authority and its partners are putting in place a whole local area system approach to improving speech. So that might be looking at how health visitors are supporting the development of language. It might be looking at how early years practitioners in nurseries and early schools, how they're looking at improving speech, so that actually that language and communication becomes everybody's business, and that yes, it is about not, yes, that's exactly what I'm saying, Ali. It's about meeting that speech, language and communication at the earliest possible opportunity, not that over-reliance on the fact that it's just a speech and language therapist employed by the NHS as part of a core offer, that then becomes the panacea for everything. We do recognise that. So we're saying, Marianne's saying she's interested in guidance for health services on the best way to work with independent practitioners. Yes, aren't we all? Especially when you go into local areas and actually the commissioning is extremely fragmented across private provision that's being commissioned and NHS that might be provisioned, and then the local authority might have commissioned some for themselves. I think that and I'm just thinking on the top of my head, I think it would be useful if the Royal Colleges could write something. I think if expectations in contracts that are awarded by schools, by local authorities, third sector and health are all clear about that sharing of information and working together. Julie, I agree. I absolutely agree. And as for parents and carers wanting much clearer guidance about this, that's a conversation we've just been inspecting recently. And one of the conversations that I was taking about with the ICB and with the local authority, they were, and also with the therapists when I had the conversations with them, was about it's all well and good having all these plans and doing it, but actually unless you communicate that to your families out there, then you are going to continue receiving that feedback that it's not working. And I also think that I've looked at some of the reports for children, young people and families from therapies, and actually I think we need to look at the language and explain actually what it is we're saying, bearing in mind, and take some of those technical terms out. So I think that there is we've got a long way to go, but I actually think that it's shifting. It's absolutely shifting. Will there be any push to ensure private providers are quality assured and meet clinical governance? That's not for CQC to answer. I think that where organisations are registered with the Care Quality Commission, that's our job to actually make sure that there's a quality assurance framework around there and that there's accountable governance. I mean, going back to what you said, Jennifer, I think that for me, I think that what you would do is put that in your commissioning documentation across and actually make sure that if schools are commissioning their own therapy support, that actually that access to governance and quality assurance are inherent as part of that commissioning offer. I think I've just said that where private providers are brought in by schools and health. Absolutely. I think that, you know, if I was doing it, I would make sure as part of that commissioning documentation and tender, I would be putting that in as an expectation. So if I could look at section 32, please. So here there's a slightly different shift, and when we're looking at set findings and evidence for section 32, it's going to be about how the local area partnership work together to plan, evaluate and develop the SEND system. So again, we've heard a lot from Andrew about seems to be in shifting sands at the moment. So this is going to wax and wane with what's happening. But ultimately, we need to know that leaders are ambitious for children and young people with SEND, that actually leaders are actively engaging and working with children and young people around that commissioning of services, and actually we're looking for co-production. Now we know that sometimes you've got to consult and sometimes you've just got to communicate, but actually a key tenet of all this is you've got to co-produce. Because actually, if you've got children, young people and their families working with you on a local solution, it's more likely to meet the needs of those communities. It's about leaders having an accurate shared understanding of the needs of children and young people in their local area. And we'll go back to local areas having an up-to-date, effective JSNA. And I recognise that JSNAs are not the only way that we can build up pictures of local health need. But they are the statutory document and they are important. And I think another key area is for local areas to harness or harvest the need that's been identified in EHCPs, because if we're cute and we write the EHCPs according to what the needs of the child are, even if we don't have the local resource to meet that need, you can then start to inform commissioning. If we always write an EHCP and the child's needs and tailor that need to what is already available, then we don't get that evolving picture of actually what the need is out there. It's about leaders commissioning services and provision to meet the needs and aspirations of children and young people, including those commissioning arrangements for children and young people in alternative provisions. So that's just wrapping up what I've talked about. It's about evaluating those services and making improvements. And it's about creating that environment in which effective practice and multi-working can really flourish. So it's difficult, isn't it? It's about that being flexible in responding to local need when you've got an ICB and an ICS who's got a much larger footprint. It's about that SEND executive lead and how they're discharging their responsibility and the links into ICS and also into primary care, because let's not forget that that's really key. It's about assurance, actually, for the ICBs on compliance with contracts. And we talked about those compliance with contracts, setting out very clearly what the expectations are in terms of provision of services and also sharing information across services. It's about making sure that the SEND statutory duties are met. And again, we're going to talk about that developing DSRs and looking at that local place arrangements, especially where you've got ICBs and ICSs across that wider footprint. Actually, what does it mean at a really local partnership level, and how actually those children and young people with CETRs who are on the DSR as well, who might end up with an unplanned admission, making sure that actually those leaders are doing that interrogation as to what happened and actually is there any learning to prevent this happening again, and then sharing that actually with their SEND partners, because very often health can't fix that alone. So let's have a look at what people are saying. So recruitment impacts our ability to deliver the service that is commissioned. Yep, absolutely. But what I would go back and say to you is look at when inspectors call, have a look at actually how you're mitigating the impact of that. So show how you're being flexible and how you're mitigating the impact where you can. I've just been into somewhere and it was about speech and language therapy, and they were able to show me that actually when I think about what else they could do to get speech and languages into their therapists into their services, I couldn't think of anything else that they could do. They were being so creative. They were working with everybody and their mother to try and not only plan for now but actually plan for the future as well. And you know, we are going to listen to that. That's the reason why we're not looking for perfection in these three areas of judgment. We're looking for where you can demonstrate that actually you're working with your families, your young people, you're working with your providers, and actually you know where your service gaps are. You're able to demonstrate to inspectors what you're doing and the impact and that trajectory for improvement. Okay, next section. An evolution. And I don't have any of the answers to this, and it's interesting to listen to Andrew when he talked about this use of place-based data to drive local services, and about actually the tension between commissioning for the critical mass to reduce variation versus the needs of local population, and the duty to again to reduce that variation and to redistribute resource. When you've got I don't know, some of the I'm thinking about the Tees Valley ICB and its footprint and all those competing demands and what that's going to look like in terms of reducing that unwarranted variation, and actually that real tension then to jointly commission services with a local authority when you're actually having to look much wider at the needs of a much wider population need. So I think there will be some really interesting and challenging dialogues around that, not just with CQC and the inspectors, but actually with the local authorities and local PCFs. We will be moving into that space around what governance is going to look like into the ICS and ICPs for SEND. We're going to be looking and working with colleagues in NHS England and also the DFE to actually what that support looks like for local areas that receive that third judgment about needing that extra support and help. We've got the continuing development of the DSR and the CETRs, and hopefully we will be able to tell that story as time moves on about how local areas and the ICBs are able to demonstrate compliance with the core standards in the framework that's just been introduced. And something else that we are really homing in on this inspection is around responsible commissioning. And I noticed in Andrew's first slides, he talked about residential placements, and he also talked about secure children's homes. Actually, for us, there's a huge issue around children in unregulated placements. So we will be having conversations around how ICBs and partners are able to come together and monitor, and for the ICB to discharge its responsibility in monitoring those commissioned placements. And we accept that there is a lack of Ofsted registered provision, and actually if you have had to place children in unregistered provision, then actually how tight is that framework, that protective framework round that child. So that's anything else that if anybody any questions? So I'll go to my last slide, which is just to say thank you very much, and we'll be seeing you soon.
Thanks, Lee. Can people hear me now, Andrew?
Yes, yes.
Yeah, my apologies. I've just called on my technical support, which in this case is my harassed husband. And my computer's died, but apparently I'm now on an iPad, so that's good. Thank you, Lee. That was really helpful. I think I really appreciated the understanding that the inspection brings to the process, but I'm really keen that we don't also lose the rigour, because inspection is a really powerful tool to push the system and to get the system to take responsibility. So we're going to be really interested in watching this new inspection framework going forward and understanding the learning, but understanding the power it has to change. We are now going on to very brave people who volunteered to tell us what is happening in their patch and how things are moving forward. And thank you very much, Alison, because these conferences don't work unless people like you come forward. So we are delighted to introduce Alison Stewart, who's going to tell us a bit about what is going on in South West London. Thank you very much, and Alison.
Thanks, Christine. So, hi everybody. I think quite a few of you know me. So I'm Alison Stewart. I'm head of SEND for the South West London Integrated Care System, was the designated clinical officer in Kingston and Richmond. We can have the next slide, please. Thank you for that introduction, Christine. As I listened to Andrew earlier, I did think I was quite glad I put these caveats in. I am going to try and avoid the acronyms. The ICS, ICB, ICP leads us into that tricky area, but I am going to try and avoid it. And actually, some of the things I'm going to talk about this morning echo what Andrew was saying earlier, what Christine's referred to in terms of, dare I say it, that slight ambiguity about what happens at the Integrated Care Board level and what happens at place. The work in South West London is work in progress. It's very much early days. And thank you to Claudia and Patricia, who are two of our DCOs from South West London, who are here today, and they'll certainly be able to bear witness to the fact that it's early days. We are looking at long-term change, undoubtedly, and obviously with the Hewitt report pending, still many questions there. Really happy to have questions or feedback as we go, either as we go through or at the end of the presentation, but it is very much, this is where we've got to, this is what we're hoping to achieve, and some of the vehicles that we're using to try and support that improvement work. Okay, next slide, please. Is actually, thank you, Andrew, the CDC's summary in terms of roles and responsibilities at place and into the Integrated Care Board. Now we have just had some agreement, or we've just had agreement across our local areas to have a system-wide workshop with the London Improvement and Innovation Alliance around SEND, and particularly looking at the sort of roles and responsibilities at the ICB, Integrated Care Board, and place-based level. I'm really hopeful that this will support our work going forward, and it certainly feels something that is really critical. Within that, we've got a number of questions as well. So we are looking at co-production with our Parent Carer Forum, and I think where we're looking at a geographical area like ours, if you could just put the next slide on, please, Miri. We've got 6 local authorities, 6 local areas, 6 Parent Carer Forum. We are having some of that sort of discussion in terms of how do we actually meaningfully look at co-production at the Integrated Care Board level, whilst maintaining the sort of sovereignty of the local areas and ensuring that we are working in co-production with each of the Parent Carer Forum. So this is our geographical area. So we've got our 6 local areas. I'm going to call them local areas because that sort of fits within the SEND agenda rather than places. But obviously that is another bit of terminology which can be tricky. But we have got 6 local areas, all at slightly different places in terms of their work around SEND. But one of the things that I've been trying to nicely hammer home is the size of the population that we're talking about. I think historically we've seen very much the sort of focus on those children and young people with education, health and care plans. And actually we are widening that conversation in terms of those children at SEN support, and actually what is the offer from the Integrated Care Board and place for those children at SEN support levels. Okay, if we have the next slide, please. So I've come into the role of head of SEND for South West London. It is the comment, and more of that later, but I think there's no doubt that our inspection history in South West London has supported the development of this role and where we are as things stand at the moment. So we've had 5 written statements of action across the local area. We've had some significant themes that are common across. So I think this has acted as a really important lever. And Christine, I'd go back to your point really around how we use the inspection framework as a lever to have some of these conversations. And certainly I think with the introduction of the new framework, there's some significant movement really in how people are looking at things. Okay, next slide. So in terms of the themes that came out from the 6 local area inspections, these will be no big surprises to any of you here. But I think possibly one of the big ones to just highlight is the lack of, as was, clinical commissioning group oversight and assurance around the reforms. That was absolutely called out within the Kingston inspection, and we have made sufficient progress there, but actually looking at all of the 6 areas, that very much is a theme that comes out. We know we've got some challenges around timeliness and quality of advice from health partners, linking into what we've talked about already in terms of some of the challenges around waiting times, etc. Sorry, dog in the background. Access to therapies, and again, I think sort of linking into what Lee was saying in terms of mitigations around access to some of the services where we know we've got national recruitment and retention difficulties that need to be thinking system-wide. We know that across our area that we've had variability in co-production and our relationships with the Parent Carer Forum, and across South West London, we've seen some real development work in trying to get to a point of agreeing a set of principles around co-production, and then looking at making some agreement with our Parent Carer Forums about pieces of work where there is going to be true co-production and where there's going to be engagement. So I think no big surprises. Variability of the designated clinical medical officer capacity and impact goes back to some of the conversation in the chat around the sort of the need for the statutory reinforcement, if you like, of that designated clinical officer role. So as I say, I think these inspection results have been useful for us and certainly have helped push forward the agenda of SEND across South West London. Interesting to hear Andrew's comments earlier in terms of how we push the agenda around children and young people, and then children and young people with SEND up the agenda within organisations that perhaps historically have had more of an adult focus. So through this, sorry, Miri, next slide, please. My role is being created, and those of you who are DCOs here will see a great similarity to your job descriptions, but very much looking at working in partnership with our directors of quality, our chief exec within the Integrated Care Board, who is our nominated lead, or nominated exec lead, and the local authority leads around the sort of wider SEND agenda. I think I put this as the last point here, but I think for me, one of the key elements is looking at actually how the role can support the designated clinical and medical officers at place, both in terms of professional development, but actually looking at where the role sits and the sort of accountability. So lots of development work here, but that is the nature of the role. It is as secondment as things stand at the moment. We're waiting to hear what will happen next, but as with everything, there's lots of things pending, aren't there? Okay, next slide, please. So one of the things that I've been quite pleased about is that I have been able to present to our Children, Young People and Maternity System Board around the SEND agenda. And I've tried to make sure that I've been linking in with some of the NHSE priorities, so including things like the Learning Disability and Autism programme, the mental health work, the need to look at transition, that move towards continuing care, all age continuing care and continuing healthcare processes, and I suppose supporting that wider understanding that we do have these interdependencies, and that whilst we may be looking at the levers in terms of the Learning Disability and Autism programme, that doesn't account for all children and young people with SEND, and how do we actually make sure that we are really reflecting our cohort, if you like, for us in South West London, that sort of 40,000 children and young people. Really trying to sort of embed this within the wider health conversations. So looking at work around physical health and the health inequalities agenda. So again, Andrew, really interesting to hear you mention that. And that's certainly something that I've been looking at with our health inequalities leads. But interesting, whilst we can pull data on things like obesity or asthma or epilepsy in children, actually that's not reflecting the fact that we may have a child with SEND who may have asthma, weight management issues, etc. So how do we pull those two things together? This has actually been quite helpful in leading into some wider conversations around how we look to develop a SEND data dashboard for the Integrated Care Board. Got to go slowly on these boards, and one of the conversations we've been having is where we've got our place-based or local area SEND data dashboards that get presented through our SEND partnership boards. What information are we looking to present through the Integrated Care Board dashboard, and actually how are we going to use it? And again, I think goes back to Andrew's point there about, you know, possibly looking then at how we work as a collective across South West London to address, I think, what you described as some of the wicked problems, but actually, you know, looking at things like recruitment and retention of therapies, looking at consistency of practice around continuing care, continuing healthcare, consistency of practice around how we make decisions about health contributions for children with medical needs who don't meet the criteria for continuing care, probably don't meet the criteria for an education, health and care plan, but they do need something additional. So lots and lots of sort of joining up there. And that's then sat very much in the context of actually, you know, how are we using our universal health services? So as Lee mentioned earlier, where we're looking at issues around speech, language and communication, how are we linking in with our public health colleagues in terms of health visiting and the wider early years workforce. Okay, next slide, please. Here we go, lots of acronyms here. So this is just to try and demonstrate how our governance structure is developing at the moment, and it is developing. We have our South West London Integrated Care System Partnership and the board that reports into the partnership. Underneath this, we've got a recovery and transition board. I haven't made it to that board yet. And then underneath that, we've got the Children, Young People and Maternity System Board. Now, as things stand at the moment, the programmes for children and young people are reporting into that Children, Young People Maternity System Board. Now, as you'll see there, we've got a SEND complex care and transition programme, details of which to be confirmed. I think one of the things there is that we're looking probably at having a SEND subgroup that will sit specifically under the Children and Young People's System Board. But I've had quite a lot of questions in terms of what function that delivers at the Integrated Care Board level when we've got the SEND place-based, local area-based partnership. So work in development. Transition we've added into that programme because we know that transition is a real challenge for us, as Lee mentioned earlier, in terms of moving children from children's health pathways into the adult pathways. But we also know that we've got really significant overlap. So, for example, the link with the neurodevelopment work that's happening, link with the learning disability and autism programme. And interestingly, I'm currently chairing the Transforming Care surgeries for our children and young people who have been in hospital for extended periods. And actually, I think it's not a big surprise, but what it's doing for me is reinforcing that need to actually let's get the system right earlier on before we get here. And how do we bring all of those things together? So as I say, those programmes will report in through the system board. Development over time, the 6 places, the 6 local areas within South West London are then represented at that system board. We're still having discussion about who actually attends that board, and I think for me that's quite a big question, but more of that in a minute. Okay, so on to the next slide, please. Okay, so in theory, this is what will happen, that we'll have each of the areas represented at the Children, Young People Maternity System Board. And I can say this in this context, it's been really useful to have the NHSE SEND maturity matrix to support the conversation about how we have a nominated exec lead for SEND within the Integrated Care Board. So in our case, this is the chief nurse, but actually we need to have a nominated SRO type lead identified at place, who then will be the link for the designated clinical medical officers, and the link for the system, the subgroup reporting into the Children, Young People and Maternity System Board. This then links in with some of the conversations that we're having locally around things like inspection preparation, you know, and actually who needs to be involved in that inspection preparation and the presentations in terms of that strategic oversight and assurance from both place and the Integrated Care Board. So that's been really, really helpful, and certainly something we've been doing quite a lot of development work on. Okay, next slide, please. Okay, so mentioned this previously. The dotted lines are there because I couldn't make the lines go dotted in terms of the relationship between myself and the designated clinical medical officers at place. At the moment, they are dotted lines, but we're having conversations in each local area about where the line management sits for the DCOs and DMOs, and then what the reporting mechanism is for the DCOs into their place, particularly around, no big surprise, impact, you know, the difference that the DCO role is making within the local areas. So we meet on a bi-monthly basis, and I am working with the DCOs in terms of delivering clinical supervision, but we're also looking at joining up on some CPD opportunities, away day type things, and we will be looking to align work plans so that we do have a more consistent mechanism for reporting on the activity that each of the DCOs are doing at place. And I'm very grateful to them for their support. Okay, the next slide, please. So we do have a number of conundrums, many of which we've touched on already today. I think that the point that Christine made so well at the beginning, that sort of system-wide understanding of changes within the world of health, and I think those of us employed within the world of health also share some of that doubt and ambiguity. And I think moving forward, I'm really hopeful that our workshop with London Improvement and Innovation Alliance locally will help us in some of that, in clarifying some of those doubts. I'll take away that word doubts, questions, shall I say. Really then looking at, you know, the sort of integrated care board statutory responsibilities and the place-based responsibilities. And again, you know, one of the conversations we've had within Richmond, for example, has been through our monitoring of our written statement of action. How do we escalate from the local area where there are concerns into the ICB? So again, we're sort of developing this as we go. Across Southwest London, we've got huge variation in local area commissioning arrangements, which I think does add to some of the complexities. Again, if we look at the sort of therapies piece, we know, as Lee mentioned earlier, we've got health. We've got contracts that are sitting within the block health contract. We've got some spot commissioning arrangements. We've got some school buy-in, and we have local authority therapy services as well. So one of the links that I'm making is linking in with our allied health professionals faculty to look at what they can actually be doing to support with some of that wider system work around recruitment and retention. Representation of SEND within priorities. I think we are getting there, but as Andrew talked about, I think for me there's something about how the work around SEND is represented within the strategy of the integrated care partnership and the board, given the volume of work there. So I think we've got a large piece of work to keep going with in order to ensure that we get SEND really sort of clearly established as a priority that is more than delivery of the statutory requirements. Relationship between the local authorities within an ICS footprint, and we've touched on this already. I know, sort of talking to our associate directors for SEND at each place-based level, one of the things we've begun to explore is the benefits of coming together as a group, as a local authority group working within the ICS to try and share some of those similar wicked problems, if you like. Multiple health providers at place also, you know, is I think quite challenging. It's challenging, but also an opportunity. And I think, again, we're sort of looking at using the inspection framework as a way of ensuring that we can bring together the health network within the local areas for purposes of support and preparation for inspection, but also then to move on and look at some of the activity that needs to take place. Clearly, the SEND and AP implementation plan will also be a lever for us. We have been, if I can have the next slide, please, Miri. We have had some support from the Babies, Children and Young People London Regional Programme, and we are working on, we're using some of that support to look at the wider integration agenda, and this is our sort of plan. It is still in draft, but you'll see here that we've tried to identify the key levers and enablers that are going to support this work to go forward, really looking at what we need in order to be able to deliver what we've said here is the goal that all children and young people with SEND will receive safe care. Really looking at sort of developing what that ICB strategy or statement of intent may be. So great to hear from Nottinghamshire, and it was fantastic, really good to see their statement of intent around that. And I think that's something that we're looking to possibly develop over time. Co-production being absolutely embedded, and I think within a very large sort of system where we do have quite a lot of engagement work, ensuring that we've got co-production as opposed to engagement embedded is quite a tall order. So we're working quite closely, as I said earlier, with our PCFs and the London Regional NNPCF to support that. We've got some real sort of granular activity there that will be similar to everybody across the board, but again, trying to pick up the learning from each of the places to support the development work going forward. And really with the outcomes, we're looking at those sort of the so what difference is this activity making? Now, again, for me, there are some challenges about sovereignty, if you like. So the improving children and young people's experiences quotes that we've got there come from the Kingston and Richmond SEND Futures transformation plan. They're similar to the other areas, but I think there's a conversation there about how do we make sure that each of the 6 areas is represented in the work that we do at the ICB level. So this is guiding the work that we're doing at the moment. It is positive, but it feels like those conundrums that I've mentioned earlier do need to be resolved before we're going to sort of be able to see the concrete benefits of this moving forward. Okay, and I think that's come to the end. Yeah.
Thank you, Alison. That was really, really helpful, really useful. I spent some time, not that long ago actually, with the Kingston and Richmond SEND Futures Forum. I think that's the last time I saw you, which was really interesting watching that in practice on the ground. But I think what I've taken from that is just the really thoughtful thinking. You can see lots of claps, and that sort of that issue about place and bigger footprint. So that's really, really helpful, and you are getting lots of applause. So I hope you can take it and realise that however challenging it's really helpful. And it's very nice things in the chat about how grateful London DCOs are to have you. So thank you. And I am sure we will want to keep sharing your learning if you're happy to share it. So that's really helpful. So thank you.
Thank you.
We are going to go on to our final piece of learning for this morning. And Andrew, you've been doing some work with Michelle, haven't you, at Nottinghamshire, and also looking at strategies. So building on the really practical, thoughtful work that Alison's doing, let's have a look at it from another angle. So Andrew, can we come to you, please?
Yes, although I can take absolutely no credit for doing any work with Michelle, who'll be talking about their approach. Just go to the next slide. I'll just remind. Yeah, so this, I'll give a really kind of just brief recap, because I said some of it. So as I mentioned, we have been looking at what's been published. It was really helpful to see everything that Alison just set out, and I think there'll be a very obvious disconnect between all that work that she's talking about that's in development, that's guiding what local areas are doing, and then what's published in strategies at the moment. But yeah, we've decided to do a review of what's coming out of the systems. It's for various reasons, but we think it's really important to get that sense and share it amongst everyone, but also really use it as an opportunity to see, at least on paper, how the reforms and how the new structures are delivering for children and young people. So yeah, I'd mentioned it previously, but out of the 42, as of last week when we did the last review, 5 ICSs have published a full strategy, and 12 have a form of draft or interim copy. Although there is a bit of a caveat, it's possible we've not been able to find some. It's not always the most straightforward. Out of the 5 and the 12, 8 have an explicit kind of reference to send as one of their priorities. Now, in a lot of those plans at the moment, it doesn't go a great deal beyond that in terms of saying this is one of our strategic priorities. And then 12 additional areas have some form of light touch. These are our priorities. These are almost a one page, sometimes an actual just single web page, and send sometimes appears there as well. And then you have a small number that just not published anything as of yet. So children and young people as a whole are well represented. There's a real focus on wider determinants of health, socioeconomic factors, and those children who have worse experiences and outcomes, mental health, obesity, preparedness for school, and SEND are the consistent factors that systems are saying they want to address. There's some consistency, but there's also kind of individual kind of flavors to the different ICS plans where it will reference analysis of local needs. We don't have a slide for it, but the core 20+5 kind of framework that NHS England have set out has featured in some strategies, and so that's the kind of the framework around focusing on the 20% most disadvantaged children and young people in an ICS area, plus 5 long-term conditions, of which SEND isn't one of them, but I think there's a really strong case that children and young people with SEND are really core element of that, particularly the 20% most disadvantaged children and young people, but there'll be lots of comorbidities between children who've got SEND and long-term conditions, and mental health is one of those as well, where it's a very particular issue. As I've mentioned before, lots of ambitions and commitments, not smart objective as of yet. And we're also looking at how plans have said how children and young people themselves have been, and families have been involved in the development of strategies. And it's a mixed picture at the moment, and it's something we're going to look into in more detail. But obviously the guidance is quite clear that children, young people and families should be a really core element of their development. And as Lee pointed out, where as much as possible, that should be kind of co-production, not just at the level of consultation or communication. Next slide, please. Oh yeah, well, here it is, the core 20+5 that people have seen. So the 5 conditions being asthma, diabetes, epilepsy, oral health, and mental health. Next slide, please. So yeah, we are pulling together the reports and our analysis, and we'll be looking to publish that at some point, I think, before the summer, but it's an ongoing process. But yeah, maybe it'd be really useful in the chat if people are aware if their own ICS has published something akin to a formal or informal strategy and to what extent they feel it reflects children and young people with SEND. And next slide. And so to kind of hear about kind of what that looks like or this process looks like in an area, I'll pass over to Michelle, who'll tell us about the statement of intent in Nottingham and Nottinghamshire. Thank you.
Hello, thank you for having me. I'm quite honoured to be considered that this is a piece of good work and good practice, and so I'm grateful to be able to have the opportunity to share this. So ideally, when the preparation for the transition into the ICB was taking place, we developed our own blueprint and our sort of transition implementation action plan, and to develop a strategy for SEND specific was on that implementation plan. Maybe if we could go on to the next slide, actually, because all my prompts are there. And so as part of the NHS England SEND maturity matrix, when they were requesting returns for key line of inquiry, we submitted that initial ICS strategy, well, our ICB strategy for SEND. Now, that was originally a piece of work that was developed by Fellowes CCG. They'd led on that individually prior to the arrangements of the app becoming implemented. And as a stage of our process, we obviously took this to our SEND accountability officer to discuss whether this would be something appropriate or whether we could consider aligning or redeveloping. She was happy with the content, so we submitted that as part of our evidence. But as a result of part of that process and meeting with the SEND regional manager, they highlighted to us that they felt that this actually didn't really encompass what we were trying to deliver from a SEND perspective. We weren't prioritising SEND across the ICS. We weren't demonstrating it clearly in that document. Now, that document basically outlined our vision, what we will do, which was to work in collaboration with our partners to make sure we meet the needs of children and young people with SEND. And then we basically highlighted our responsibilities. So we then decided that we maybe need to relook at that. So we advocated that with our SRO to have discussions wider about reviewing the strategy and be more specific with a statement of intent to underpin that strategy. So that was agreed. But again, it was about the content and what we were going to be putting in there. So I've got a really good support network within the East Midlands DCO network group. We all work together on numerous asks from NHS England. We try to be consistent and robust in our responses, and we all decided that we would probably develop some kind of statement of intent. We worked together on what the type of topics that would include, and then we went off and developed our own sort of draft to take back to our ICB leads. So for us, this statement of intent kind of includes what we detail the ICB's role in implementing the SEND agenda. So what that understanding of our commissioning requirements are with respect to meeting the needs of our children and people with SEND, how we're going to work in partnership with our local authority, and then also we wanted to highlight what we expect from our ICB and health providers, what we want them to make sure would act on to be able to meet their duties and meet the needs of our population. Maybe strengthen what our governance structures look like and what that leadership looks like, so it was visible and people are service users, children, young people and families have that good clear understanding of what that was going to be outlined for, and focusing on the co-production element as well, what we were feeling, what our next steps were going to be to incorporate that across the system. And we also wanted to make sure that we were clear on what services were available with it, so that families knew that for children and young people with SEND, what could they access, what is already commissioned, and obviously that would then help determine our gaps if families would wanted to share that they had their needs, felt that needs weren't being met, etc. So if you want to go on to the next slide, it's really a really brief overview, I apologise. And so the whole process helped strengthen our development, really, because we were aware that we didn't maybe have really good, clear governance structures. And that, like I've said earlier, the key lines of inquiry from the maturity matrix, also those key questions helped bring that to the board, make sure our executive leads were fully on board with what was expected from them. So we drafted the statement of intent. Everyone at executive level approved it. It went out to all our partners across the ICS, health trust providers, parent carer forums. It was taken through to our SEND Health Assurance Group, which is a subgroup that sits underneath our SEND Accountability partnership board, to make sure it got out to the wider partners within at place level, and everyone approved it. So we were able to then consider how we were going to publicise it, and so our next steps were to link in with ICB comms team. So originally they wanted us to, obviously I as a DCO sit within our ICB safeguarding team, and they felt that at the time that maybe send could be facilitated on their platform on the ICB website. So we went through those steps, and it ended up just being a little icon for send on there. Really difficult to find. There wasn't like that central point where if someone put send in, they could actually locate our information. Once the site was developed, I shared it with the Parent Care Forum, through our other partnership providers from the health, and to our NHS regional lead for comments and feedback. They all felt that we needed our own platform, our own landing page. So that gave us the confidence and the strength to go back to escalate this through our ICB leads, and it was agreed. So we've been working on that platform. So the platform that's available at the moment has been contributed and co-produced with all our partners. However, it still needs to evolve. Images and maybe content might need to be tightened up, and we're just waiting for people to feedback to us. It's been circulated across, and it's accessible now, and it's the links on this slide for anyone that wants to have a look at it. Sorry, I rushed because I was told I had 5 minutes, and I think I've just gone like rah, 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 rah. So that's me done, I'm afraid. If there's any questions and you want more detail, I'd happily have people contact me outside of this
that was
forum.
really, really helpful. Oh, really helpful, Michelle. I think just checking. Said somebody had raised their hand, but I think people are just clapping. You can see lots of clapping.
I think I was only asked to give a brief step-by-step approach, so that's what
very
I've done.
efficient. Somebody said, remember, Michelle, the reason people are so impressed, the reason I was impressed when I saw your statement of intent is because it's actually really clear. And I think for us, as Andrew said, we've been watching this evolving work. We've seen some really good stuff as governance has started to develop. And you see that really thoughtful process Alison was talking about. But in terms of having something which is accessible to people and clear, I think that's what caught our eye in the work that you were doing.
Okay.
So that was really, really helpful. And
Yeah.
there were lots of claps. We do have a bit of time for questions. For some reason, we've been very efficient, which is good, and not helped by my computer crashing. But anyway, so if anybody does have any questions or thoughts, do put them in the chat. Or if you're just sort of trying to absorb all of this, that's also fine. We know that we're giving people quite a lot of information. Who is responsible for updating and maintaining the site, Michelle, for example, is a question.
So it is our comms team. They review regularly, and they will come out to myself and partners to ask if we have any additional information. And I have an associate DCO who sits on our local offer development forum across both local authorities, and she's responsible as well for making sure that things are up to date and making sure amendments are shared. The website also has links to our local offer websites and vice versa, so that parents, whatever forum they use, are able to access it.
That was preempting my question. I was about to say, how does it link to local offer? So that's really helpful. So it's just trying to build those building blocks, isn't it? That sort of front-facing world that parents and families can update, and those of us outside health that we're still trying to work it all out. All right. Oh, somebody else interested in websites. Are you, Michelle, or somebody else able to record how many hits you get or how many people use it?
So on the local, I've only just launched it, but on the local offer website, they're able to record it, and the local authority share that with us. And I guess I need to go back to our comms team and see how I can get that information as well. So that'd be really useful. We could probably use that for our early development of any send data dashboards as well. It might be something to add on there.
Yeah, we've just started to be able to look. Obviously, as CDC, we've done a lot of work on data and data dashboards, and worked with many of you on developing that. And we've just started to look, or Anna, who leads our dashboard work, on the DFE, which is now wanting to produce local and national inclusion dashboards as part of the SEND improvement plan, and that information will start to come round fairly soon. I think we've just started to see the sort of prototypes of that, and partly what we've been interested in from our point of view is making sure that health data is amalgamated in that, so people see the whole picture. So as that develops, we'll also share that with you so we understand how that fits together. For people who've asked about slides, we always share the slides. We're very grateful to those presenters who come and give their time and knowledge to us. So all of the slides will be shared and the session itself is fully recorded. So should you be having a cup of tea and thinking, I know Michelle or Alison said something incredibly useful, but I need to check where it was, you just have to press a button. So it is all there. And as Andrew said, this is a sort of emerging piece of work. I'm really keen. I do some work with directors of children's services, and what is really interesting to me at the moment is this is their biggest concern. So they, as the local authority, and if you think about the things we've looked at in place and footprints and all of that, is trying to work out themselves. So where do I fit? Where do I fit in the partnership? What does that mean? How does that work? And I suppose what's my set of expectations? You know, I think Lee was really clear that they're going into inspection not to look for the perfect, but for look at the best that's possible. And I think it's getting to that understanding at the moment between the big agencies and with families about what is the best service that is possible now, but also what is the best service we should be trying to achieve. So we don't take for granted that. I think the latest figure, for example, that I saw this week from the NHS on waiting times for autism assessments or waiting lists was, I think it's now got to about 140,000 children waiting for autism assessments, for example. Now, that's clearly not good enough, but it's about understanding where that is and understanding in the planning process how, the next stage is for sort of taking that on. I think the other thing we're interested in looking at as the improvement plan develops, some of you will know if you've read the 100 pages or whatever it is of the improvement plan, that within it, I can't remember what it's called, maybe my team will remember, there is a big piece of work from the NHS in one of the regions on access to speech and language therapy for children. Andrew, can you remember what it's called? I've gone completely blank.
The early language element. Yeah, I can dig it out. I can't remember the exact technical phrase they've used.
Neither can I. But as part of the improvement plan, one of the contributions from the NHS towards the overall plan is a very specific and quite big pilot piece of work across one of the regions, yet to be determined, for example, on each access to speech and language therapy. And we will make sure you know about that and post that as we also begin. Oh, look at that. Thank you very much. Early language support for every child across 9 Pathfinder sites. You see, that's why you're always hopeful you have a knowledgeable audience. Thank you. So understanding what that is, and more of that will come because it fits into that. How can we eat this elephant of backlog? We're going to do it in chunks. Okay. Right. I think as we have got to 10 to 12, and you've had a lot of information, my only job, thank you very much for the slide, is to ask you please to fill in the evaluation form. These webinars are delivered under the one of our DFE contracts, under the RISE contract, and we have to prove to the DFE that they are useful to people, because then we are able to keep running them. So if you can fill in your evaluation form and we can tell the DFE that they're useful, we can keep running them, and we will be working with you and across the sector to understand where the best focus for these mornings are as we move forward. Andrew, do we need to add anything else?
The only thing that I thought might be relevant is because Lee was mentioning it as well around the residential care commissioning and provision and like the ongoing monitoring of that. I just wondered if it was worth saying just a little bit about the timeline of the safeguarding panel report Mark 2.
Sure. We many of you will know that as CDC we've been working with the National Safeguarding Child Practice Review Panel, words like that anyway, to look at some very complex abuse of over 100 children at Hesley schools in Doncaster. And what came out of that really clearly, and it's really interesting because it's the first thing that Alison said on her headlines from inspection, was a lack of assurance and oversight from health. Health as key players with this group of children, who were all children who had a number of diagnostic criteria, but primarily autism and challenging behaviour. We are at the process, we've done a lot of work with NHS England and others, of going to second stage report, which are the national guidelines for making practice safe for this group of children. And we are expecting that report out in April. Not sure when, because it depends on number 10, but there are some significant recommendations in that for ICBs. So, and for commissioning for complex and expensive children. Once that comes out, we will want to do more analysis on that with you to help you think through what that means. So basically, these are low incidence, high cost children who could and are in either 52-week residential schools or in Tier 4 provision or in secure welfare, or as Lee said, increasingly in unregulated provision. So we're trying to understand how to bring the strands of health, education and care together around this group of children. And actually, the ICB footprint will be a better footprint for this group of children than each local area, because they are a low incidence commissioning group. So we will come back and talk to you about that as the report comes out. And obviously, when the report does come out, we'll let you know and we will publish it as soon as we can. So that's where we are on that, and you will see and gather that we've been working quite closely with Lee on that as that work unfolds. So thank you all very much this morning. Thank you indeed to our speakers. It is always so important that we hear from you, so thank you very much indeed. Thank you for putting up with me in my technological meltdown. But you know, I have now learned how to use an iPad and Teams. It's a big achievement for me. All right, take care everyone. See you soon.